Welcome to this week's topic on global policy issues and achievements in NCD prevention and control within our NCD online course. Let me give you first a little outline over what I want to discuss in this presentation. First, allow me to give a little background about NCDs again, especially on those arguments which lifted NCDs up to the global agenda. Then I give an overview on the UN declarations and resolutions, which culminated in the September 2011 UN meeting in New York. Then I talk specifically about the NCD indicators put forward by the WHO for the UN. And with that, we leave the UN framework or the global framework and to look specifically at the European NCD action plan and what is different there, and focus specifically on fiscal measures to control NCDs. And last but not least, I want to introduce you an alternative framework of monitoring coming from the Lancet Action Group for NCDs. Now, as you remember, four main NCDs, cardiovascular disease, cancer, diabetes, and respiratory disease, were selected as they represented about two-thirds of the global mortality. This was then always resulting into the discussion why those four and not other four, because other NCDs, for instance mental health, at least in morbidity, are also a very significant contribution to the global burden of disease, and certainly bigger than, as we saw in previous lectures, bigger than diabetes, for instance. The argument why those four were included and others relied always on the four main risk factors shared between the four, this 4x4 table, and also that, and this is a distinction to mental health, that cost-effective interventions are available addressing those four risk factors. Hence, in the UN high-level meeting, only those four groups, risk factors and NCDs, were invited, and the resulting WHO NCD goals, targets, and indicators are centered around those. This is now the famous grid 4x4, here the shared risk factors, and here the four key NCDs. But you could argue also, if you add here at a fifth line mental health, then you see also some commonalities, of course not causal, but at least a relation to tobacco use, harmful use of alcohol, physical inactivity in relation to mortality from mental health. So one could argue that other NCDs should be included, but in the process, in the policy process we're describing here, leading up to the UN meeting, it was decided to have only those four main NCDs participating. Another argument for the prevention of NCDs put forward was that about 25% of the total mortality would occur below the age of 60, and that is considered as premature, and therefore it should be preventable. The next strong argument was looking at where, geographically speaking, those NCDs occur. And if you look here mostly at the orange bar representing low-income countries, estimates 2004, projections 2015, and then 2013, you see that the biggest increases occur in those countries as opposed to the high-income countries. So that makes NCDs a global issue, with especially hard impacting the developing countries and not only the rich industrialized countries. two more arguments in the policy development of NCDs, global policy NCDs. One was this significant placement, if I want to say so, of NCDs, here the NCDs, here they are, into the discussion of poverty, demonstrating that risk factors, the exposure to risk factors, can contribute to a loss of household income. If you think about the significant expenditure a smoker, especially in developing country, has to do to maintain his habit, but then also the disease, once it's occurring, has the great potential to contribute to a loss of household income and to increased costs from healthcare with a limited access to healthcare in those countries. So the conclusion there was that poverty contributes to NCDs and vice versa, NCDs contribute to poverty. Finally, another agency other than the WHO, it's an NGO, actually a private foundation, the World Economic Forum, based in Davos, Switzerland, came out with a global risk report in 2010. They're doing this now every year, where they looked at different risks in terms of their severity, the damage in US billion dollars, sorry, and versus the likelihood that those events would occur. And NCDs are, unfortunately, or fortunately for lobbyists, you could argue, in the top right corner, close to the asset price collapse. And remember, this assessment was done in 2009 at the beginning of the global financial crisis. Another very powerful quote from this report was that NCDs are a problem neither the developed world nor the developing world can afford to ignore. What they meant. For the argument that current development frameworks are not covering NCDs, was used this statistics demonstrating that in developing countries about 8 million deaths premature from NCDs are not covered by the current MDG goals, and therefore you find now in the post 2015 discussion what should replace that MDG goals. You find the NCD lobby being very strong, saying in a new round NCDs need to be somewhat represented in one way or the other. Now the last argument was presented here, looking at the assistance, overseas development assistance available for the different vertical programs. Here you see statistics from 2009. I think there are now newer statistics out there, but the tendency is pretty much the same. You see certain vertical programs and diseases highlighted by a massive available resource, whereas NCDs on this different with those groupings are actually not showing up because they are actually within the OECD, not a separate heading. So it's quite difficult to track their progress, but as an estimate, 500 million out of this 22 billion were estimated to be given to NCDs, which is around 2% for a condition which is 2/3 of the global mortality. Now let's briefly look at the timeline and the development of the UN NCD policy stream, and you can see on this quite busy scheme of timelines in the upper part policies and events happening at the WHO, whereas in the lower half events at the UN level, culminating in last year, September 2011, the high-level meeting on the prevention and control of NCDs in New York. And you see in the lead up, we already had a global ministerial conference on healthy lifestyle and NCDs in Moscow. And I'd like to highlight this one or emphasize this one because that was a conference of ministers and not necessarily ministers of health, despite many of them were ministers of health who are represented. So this is the UN process, as opposed to the process of the technical agency, WHO, where you of course would expect that there are many, many more resolutions and sessions in the lead up. And actually this earliest timeline here, looking at the global strategy for the prevention of NCDs, is not necessarily the first step in NCD prevention and control policies on cardiovascular disease at the WHO go back more than 40 years, I think. So here you get a nice overview, and if you want to dive into the details, I recommend you to go to the source of this slide and the presentation where I have it from my colleagues at the People's Health Movement, and in particular from their section called WHO Watch, a very interesting source of information you should consider. Now let's come to the last publication before the seminal September 2011 UN summit. In the lead up to that summit, there was the report of the Secretary General on the prevention and control of NCDs. And here is a bit of a summary, nothing surprising for you in there, but very strong statements saying that NCDs are rapidly rising epidemic in developed and developing countries, serious socio-economic impacts, especially in developing countries. Solutions exist, and the way forward, these solutions need to be mainstreamed and implemented and monitored. As an interest, the document, the resolution after the meeting, which I also make available to you, like this one, had, because it was then negotiated with the heads of statements and so on, toned down quite some of that language, and especially an interesting point in the negotiations was the questions, are NCDs an epidemic, as it was pointed out, even a heading in this May 2011 report is saying NCDs are an epidemic and so on. Later, the only reference to epidemic which survived was that NCDs are a problem of epidemic proportions. And you might think, well, that's just language, but actually it has also political implications. But let's go to what happened then in New York, September 2011. During 2 days, 113 member states met at the UN. 34 presidents and prime ministers, 51 ministers of foreign affairs, 11 heads of UN agencies, hundreds of NGOs, and one participant from Denmark who is currently talking to you, but unfortunately not on this slide. So I had the opportunity actually to be there in the General Assembly Hall down there. You see a photo of it. What happened, the key outcome is obviously the political declaration on NCDs, and in there, especially in this presentation, we focus on the aspects what WHO was tasked to do and or volunteered and prepared themselves to do, and that is to develop the global monitoring framework and its targets, and they were just confirmed or approved in May, now in June 2013 in Geneva. The global implementation plan coming from that, WHO wants to provide more technical support, identify options for partnerships, and coordinate the work between the other UN agencies. Because remember, this UN high-level meeting was not a WHO meeting. It is really the second time in the history of the UN that the UN met on a health issue. And you can guess the first time was in, oh boy, 2001. If I'm not completely wrong, I need to look it up. At least it was on HIV/AIDS. So the second time now they got together and decided there to adopt a global target to reduce mortality, the premature mortality from NCDs by the year 2025 by 25%. So 25 by 25, it made a nice, and it does make a nice slogan. What people overlook it is, but which is extremely important, is to remember it's the premature mortality. Because if you look at demographics and you look at the natural history of age-related diseases, and NCDs are such, then of course the overall mortality will go up with increasing aged population. So we are talking about a reduction in the premature mortality. Coming back to the policy process, so this meeting was obviously a result of many steps before, working groups, etc., consultations with member states, agencies. It was actually an extremely busy time for WHO, resulting then after the meeting in further consultations about the targets and goals, which were then adopted, this 25 reduction paper, and then the targets to be measured was being published in July last year and discussed in the second half of last year and finalized in November, and concluded to be presented then in January. You see, it's all very rushed and hectic. The different steps which had to happen in January, it was presented to the executive board of WHO in order that it could be discussed in May/June, just a couple of weeks ago now, at the annual World Health Assembly. And I'll attach also to our web platform the current resolution from the World Health Assembly. It just came out last week, where all the targets and indicators were adopted. Coming up in this process, policy process of NCD prevention and control at the UN level, is that WHO has to give a report to the Secretary General in September, and there will be another smaller meeting at the General Assembly to look at the progress support and to have then a review in the following year. I've flicked around a couple of key terms. The global monitoring framework for one of them. That's the conceptual outline designed by WHO for monitoring and evaluating countries' actions to prevent and reduce NCDs. So that information should all come back together at WHO to be presented back then to the UN system. Indicators, clearly, to repeat here, are measures to track and assess progress over time, so they're central. And you see later why I'm insisting on those terms. There is a lot of meaning attached to it and consequences. And then I also want to highlight, or have to highlight, that the documents are speaking of the 9 targets, but they are voluntary global targets. So yes, a target is a specific aim to be achieved, time-bound, etc., but voluntary indicates that there's no legal obligations of the countries to achieve them. And that is, of course, a very weak and soft spot in the whole declaration. But was it ever possible to agree on binding targets? That would be, in this time frame, in my opinion, very naive. If you look at the FCTC, the Framework Convention on Tobacco Control, with binding targets that took years and massive efforts of lobbying, an effort we as NCD community haven't had the time to achieve legally binding targets. Now, of course, targets are great and they should focus global attention and should reflect and represent then the major contribution to the achievements in NCD prevention. And it was decided to set the targets for 2025. You heard the slogan, 25% reduction by 25. And as baseline, it was set the year 2010, which is interesting. It was decided in 2013 or proposed in 2011-12 to basically have a baseline retrospective. So that means targets and indicators were set after the baseline measurement was done. It is a very far from ideal situation, as you can imagine. Now, Margaret Chan at the meeting excelled in her presentation by saying what gets measured gets done. And there was a very powerful presentation she did and very powerful slogan. I normally like a lot that one, and there were many countries from developing countries supporting that statement and saying, well, if you don't give us any targets to our politicians and decision makers, if we don't measure it, nothing will ever get done. Yes, I agree in the power of this statement. However, I'll see it also the other way around. Things which don't get measured, things which didn't get listed as target or indicator, there we actually are not sure if they are actually getting done and so on. So it's very important to look at the list of indicators, because, and not only what is on there, but I encourage you also to look onto it, what is not on there. And I think there are a couple of important things unfortunately missing. So developing indicators in the policy process always has a lot of intended, but maybe also unintended consequences. Now, what is the global monitoring framework proposing, or what was decided, sanctioned a couple of weeks ago? Those are 9 targets and 25 indicators, and you can group them along mortality and morbidity. That's the premature mortality, from cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases, the top 4, and also a reduction on cancer incidence by type. Then we have the some indicators on risk factors, 3 on measuring progress on reducing harmful use of alcohol, then 2 on obesity, 2 on physical inactivity, and so on. And the last one are on the national systems response, quite often healthcare system response indicators and like screening programs, access to medicines, basically secondary prevention progress and things like that. And let me now share with you the latest document of this series of UN policies on NCD prevention and control. This is the one I mentioned before, just came out last week, a follow-up to the political declaration of the high-level meeting in New York on the prevention of NCDs. And I can proudly say that both Denmark and Switzerland supported that resolution, and it was passed the other week. And this document I make available also on the web spells out exactly those targets and indicators. And with that, let's move away from the NCD system and look at what Europe does. I also included in your resource material the European NCD Action Plan, which was developed to some extent in parallel, side by side, the UN movement I described so far. So to some extent you have to realize that what is included there might not be included at the UN or WHO headquarter level, because there were those discussions, as much as they tried to coordinate, they to some extent happened independent. This is an interesting plan in its own right, where you see those 4 priority areas: planning and oversight, health in all policies, healthy settings, and secondary prevention. And if you have the list of the indicators from the previous slides, those ones and the other ones in mind, let me quickly come back to this one, then you realize that some of those ones you can easily find here: salt reduction of trans fats, and early detection of cancer screening program, risk assessment management in high risk people or people with already an event for secondary prevention. But then other areas, active mobility, fiscal policies I like to focus on now, are not really reflected by those indicators. And that is what I mentioned and meant before when I mentioned that if you say, well, what gets measured gets done, so if we don't have any indicators on progress of fiscal policies, what is then the incentive for the global community to work on those ones? Highlighting fiscal policies now, I like to, because that is, I think, a very powerful tool in controlling some of the key risk factors: tobacco, alcohol, and certain food consumptions we should as societies look at. Of course, very much linked to the political systems. You remember the discussion about the nanny state, that people of more conservative political leaning are saying we don't want to have the state prescribing what I can buy or consume and when and what not. And here's a funny link to the Guardian Research Department, where they mapped out the political leaning of systems in the countries at the beginning in, I think that's 2000 and around 2000 across Europe, towards then the end of 2011, where you see the color red symbolizing the more social democratic governments, then having almost all turned into blue, the more conservative ones. And you can imagine that draft resolutions from 2009 or so might not find, when it is about signing off on them, the same support by the governments once they change their political framework and belief system. So you always have to, when thinking about policies, to have the context, the policy context also in mind. And that might explain also, when you analyze the different policies, policy action around food and marketing of food across Europe, you find some good examples. The dietary guidelines, for instance, you find in almost every country available. Subsidized fruit schemes in schools, also very popular. And amongst the less popular one is promotion of active travel, with Denmark and Copenhagen a notable huge exception there, and signposting of food products and so on. So all those decisions are way beyond the healthcare system, and are intricately linked to the political discussions, and you need to take in those contexts to understand why certain countries make progress and why in other countries it's extremely difficult to move forward there. In my brief primer on fiscal policy, I wanted to just point out that if you consider analyzing the potential of a fiscal policy to control tobacco, alcohol, or certain food products, then certainly you need to look at the evidence, the current practice, what is currently done in the country, and then of course the social impact of this idea. So as quickly going through among the evidence, the effect of on consumption, elasticity, things like what if you put high prices on certain products, can people move to other products, or are they willing, how long are they going along with price increases and so on. Then you also have to not look only at taxes, but the other the other side of the coin, the subsidies, selective subsidies. The current practice has now to certainly include a consideration on what is the relation to the current financial crisis. Is it now a good time to talk about increasing taxes? Especially in Europe, in terms of tobacco, our concern is about smuggling or illegal production of alcohol in the East and things like that. And last but not least, the social impact, the regressivity. Could it be that a tax hits the poor more than the rich ones? Could the effect be different on different socioeconomic groups? And last but not least, of course, what is the health impact? Because I remember one example from, I think that was the Pacific, where there was a 5-cent tax on soft drinks, which had absolutely no impact on consumer patterns. So people were consuming at the same rate as before. But of course, it was a nice tax income for the Minister of Finance. So Minister of Health neither saw the money nor the health benefits, whereas the Minister of Finance was very supportive of that. All those things have to be considered when you want to plan and use this otherwise, I think, very powerful and very important tool, fiscal policy, to prevent NCDs. I'm closing this presentation by highlighting a little bit an alternative approach, or to say that there's also another group out there discussing alternatives, and they're around the Lancet NCD Action Group. And we launched, I have to declare my, not conflict of interest, but my interest, because I'm proudly member of the Action Group. We launched this year in February the 4th series, a number of articles around Robert Beaglehall, and I'd like to point out 4 important articles. One of them, I come back to that, is the measuring progress on NCDs, then an overview by Richard Horton, but then also NCDs, a challenge to sustainable development, written by Helen Clark, the head of the UNDP, showing that NCDs and developments are 2 interlinked issues, and we have to move out from the narrow view of NCDs is only a health or a medical problem. And then Robert is making the point of an independent global accountability. I'll show you also that point because I like it very much. So in his paper, Robert is proposing actually 1 global goal and 5 targets as an alternative view to WHO's 9 targets and what did I say, 25 indicators. Robert is very strongly saying this is way too much, too complicated, too onerous to get a global agreement and global progress. So he says, why not only focusing, picking out 5, that's enough. He is very strong on tobacco control, and he says that the targets formulated by WHO are way too weak. There he wants to see much stronger progress. Reduce dietary salt and treats people at high risk for cardiovascular disease. Reduce physical inactivity and reduce alcohol consumption are his favorite 5 one. So he's very much into make it simple, but Einstein would say make it simple but not over simple. Then the last point from this series, and please have a look, I'll have the link on our website, is what I'm always thinking also, who is evaluating the evaluator, who's monitoring the global monitoring framework of WHO, if this framework is actually delivering what the world community wants. And he's proposing that somehow, somewhere, there needs to be an independent expert review group on NCDs, which should look after the global monitoring framework, which is proposed by WHO and should then trickle down to the countries and also reported back to the UN Secretary. So you see lots of activities going on, but equally, a lot of questions haven't been fully answered or thought through. And this concludes our session on global policy issues and achievements for NCD control, but not without that I'd like to acknowledge my friends and colleagues, and especially in this context, Ruth Bonita and Robert Beaglehall, Gordon Galea from the WHO Euro office, and then my friends and colleagues also from the Lancet NCD Action Group.